Good evening, good afternoon, good morning, or whatever time it is, wherever you are. This is Dr. Brian Novi. I'm thrilled to be with you right now, talking about caries. As I'm assuming most of you by now, we've run into each other at some point in time, and I see the number is climbing. I see 150 to 156 people now logging in. I have to admit, I was just telling the folks at Viva Learning as we were getting ready to start this, that I couldn't see how many people were online. And I started getting really discouraged going, doesn't anybody care about caries anymore? But now I see it. Now we're about 194 people logging in. So I'm thrilled. And I just want to say, I appreciate all of you giving up an hour of your life to come listen to me talk about tooth decay. And hopefully I can give you some tips and tricks for ending the curse of caries. So let's get this party started. And first, an update for those of you who know me. I've had a big life change recently. I have uprooted my family, and we made another move. And I'm now Chief Dental Officer of a practice called the Alliance Dental Center, about 12 miles south of Boston. This is an amazing brand new dental office with a comfort dog named Simon. Those of you who know me know my dog Simon. Simon is our official comfort dog in the practice. We are an incubator clinical site for the Massachusetts Public Employees Fund. And as Chief Dental Officer, it's very, it's an incredible journey to be able to run a dental practice where we provide care to state employees in Massachusetts. I get to practice in an environment where if you're a state employee, you get dental benefits in this office, and everything is covered at 100%, no copay, no maximum benefit. So it's an amazing place to practice. But what I'm finding is a lot of patients who have been really hesitant to seek care for many years because of numerous barriers are showing up at our door. We've been open for almost 6 weeks now. We just saw, I believe, our 150-something patient this afternoon, and you'll get to meet my new assistant later in the lecture. I've got a picture of Katie to share with you, and Katie is on the webinar. For those of you who are wondering, does he actually do this stuff in practice? My assistant and I were working on a patient literally until, Katie, I don't know what time we finished today, but I ran back to my apartment, showered, came back to the office. Now I'm giving a webinar. But if you're wondering if I actually do this in practice, I've got Katie online, and she can tell you what we actually do in practice. And I see we're already jumping into the Q&A. I'm going to hold off on answering anything with the Q&A for right now. Anyway, more to say about this practice. We've been seeing that a lot of patients who haven't received dental care for years, many of them have rather complicated medical histories, complicated dental histories, and are looking for really comprehensive care. And all of a sudden, everything I know about caries is I'm finding I'm practicing this stuff literally sometimes 10 hours a day, 4 days a week, running this office with a team of now 12, providing care to these employees, and we're bursting at the seams. And I'm excited to share a patient case with you this evening. This is what our office looks like from the back of the front office. There's Simon looking out the window for the first patient of the day to roll in. Nessie at our front desk there. And those of you who know me know that I like to refer to the first impressions team rather than the front desk team. They're not a piece of furniture. They're the first impression that people have when they come to the office. And it's great that we have Nessie sitting up front, the voice on the phone, and the voice of an environment where we're actually going to take care of you. So much so that we want to look at how do we improve the prognosis of your care. So we've got to go through a full disclosure. You need to realize that Viva Learning is paying me to be here with you this evening. And throughout my career, I've been paid by lots of different dental manufacturers. This particular webinar is being supported by GC America. Those of you who know me know how much I love GC America products, and I'll get into a little bit about how this webinar came to be in a second with GC America. But I've also received money from companies like Straumann, Shofu, Clear, Solution Reach, Air Techniques, Carry Free, Philips, I've acquired Trident, SDI, Voco, GlaxoSmithKline, Mars Wrigley, and Church & Dwight. They've all paid me at some point in time. I'm not here to sell you anything. I'm just here to tell you what life is like in the trenches of practicing dentistry on an extreme caries risk population. So I really don't care if you buy any products after tonight, but hopefully you can leave us some tips and tricks. I have faculty appointments at 3 dental schools. Those are Loma Linda University, Western University, and Harvard School of Dental Medicine. When I left Loma Linda 6 years ago and moved to Massachusetts, I left behind research funding from a company called Origenics, which is now ProBiora Health. You don't hear me talk about probiotics very much, but in the future, you'll be hearing me talk a lot more about probiotics because I think the research just continues to build, especially for products like that which Origenics and now ProBiora Health actually own. And now in my current role, I'm the Chief Dental Officer for the Alliance Dental Center. So that's my full disclosure of all the information you need to know about me. But what are our objectives for tonight? Here's what I want to do for you tonight. I want you all, as clinicians, as people who are out there living the dream of working with patients, I want you to minimize your lack of retention events, especially when it comes to using glass ionomer in private practice. I want you to design restorations that maximize tooth structure preservation, meaning I hope that after today you can get a little bit more comfortable leaving caries affected dentin and knowing how to actually use glass ionomer in such a way that it can actually remineralize and drive ions into the teeth. Hopefully you'll see less recurrent decay at your recare exams. And overall, I really just hope that I can help you apply evidence-based treatment recommendations to end the restorative cycle. And the restorative cycle is as I mean it here, is the cycle that begins the moment we touch a tooth with a drill, a handpiece. The moment we touch the tooth with a handpiece and we start that process of making bigger and bigger holes in the teeth, which we all know just lead to more recurrent decay. And so what can we do? How can we change our procedures and practice to actually help these patients, especially in that restorative cycle, and actually just stop, get a restoration, and improve the prognosis of care, right? So really what we're saying is, I think all of us on this webinar today have this mission and a vision that we want to improve the prognosis of what we're doing for our patients, because we want our patients to come back because they're healthy, not simply because we find something else wrong with them. And I love the phrase that I've been using with all my new patients. Each time I meet them, I say, let's get one thing clear. The most important thing to me is to figure out what matters to you and help you bring that to fruition. So what is it that matters to you? Let me focus on what's the matter, but what's the matter is not as important as what matters to the patient. So let's focus on what matters to the patient, not what is the matter with the patient. I have to tell you though that we're gonna have a quiz at the end. We're 7 minutes into this and now there's a test coming. So there's gonna be a quiz at the end of this. I have written a quiz with 5 true or false questions. True or false, I decided to not do multiple choice this time because my true or false questions are hard enough. But you got 5 true or false questions. I have the true or false questions next to me right here. So when you see a slide with a yellow star on it, I guarantee you that could be something important. And so I'm going to try to drive home a point there that makes it really easy to pass that 5-question quiz at the end of this. So if you see a yellow star on a screen, that's your cue. Take special note. This is an important topic that may possibly, almost definitely be showing up on a quiz in your near future. All right. How did this all come about? I don't know how many of you read Dental Product Shopper, but in February of 2019, I was on the cover of Dental Product Shopper. I couldn't believe how many people actually read Dental Product Shopper by the amount of text messages and emails that I got from people saying, oh my gosh, it's like you're in my office with me. I look down at my desk and there's Brian Novy staring back at me. This was the moment in my life when I realized I have no hair on top of my head. Until I saw this photo, I actually thought, wow, there is still hair up there. But now that I see this, there's nothing up there. It was a wake-up call for me. So, but what got me on the cover here was talking to GC about this new product they've created, because I've been on GC's case for years saying, can we please come up with a glass ionomer that doesn't need a triturator, something that's easier to use? And they've done it. We now have resin modified glass ionomer, which doesn't require a triturator. And so for those of you who are hesitant to use a glass ionomer simply because you don't have a triturator in your operatory, and I'm talking to the hygienists in the audience who are doing sealants, you can use resin modified glass ionomer without a triturator using this fantastic gun. And that makes it easy. But in the end, all of us see these really extreme caries risk patients. And in the end, the point is, I want to share with you some extreme cases of where glass ionomer has done its job. And when you experience a lack of retention event for a glass ionomer restoration, it's because the patient's mouth is so conducive to caries lesions, they're going to demineralize their glass ionomer restorations instead of their teeth. And that's exactly what you want to have happen. If you put composite in that patient's mouth, they're going to get recurrent decay. But because you chose to use glass ionomer, you're going to watch that glass ionomer slowly dissolve away. You may even see a caries lesion form in the glass ionomer. Shocker, I will show you clinical evidence of this coming up in the webinar. But you may see caries lesions form in your glass ionomer. Now, I'm not saying caries lesions. I said caries lesions. What I'm saying is you may actually see a localized area of demineralization eating away at your glass ionomer, which tells you you used the right material. That was absolutely the right material to use for that patient. Because if you had done composite, you would be waiting months, maybe years, to find out there's recurrent decay that is now penetrated so far into the pulp, you're probably going to do a root canal pulpotomy or some other form of treatment. So what I want to kind of emphasize tonight is, what can we provide our patients that actually give glass ionomers a little help to maintain their caries resistance? Because we have to remember, these glass ionomers are dynamic materials. They're going to recharge, they're going to remineralize, their ions are going to be depleted because they're releasing them into the tooth. And so adding things like CPP, ACP with fluoride, adding things like fluoride varnish on top of your glass ionomer, some of the new cool technology like Curidont, which I've been getting to put on top of my glass ionomers a little bit, that technology allows you to recharge these materials so they become even more caries resistant than they were when you placed them. All right, so let's get clinical. Katie, my assistant, is listening to this webinar right now, and Katie, I'm going to try to not violate our favorite patient's protected health information. This is a patient I finished my day with Katie. Actually, I take that back. After this, I went and saw a 5-year-old for their comp oral. But this was the patient that I spent 2 hours with today. And this is my odontogram from EagleSoft. This is my treatment plan for this patient. This patient, I thought my team, my brand new team that I came to join, I thought they were playing a joke on me. The first day in clinical practice, when we opened our doors up to the world, the first patient who came into a chair for a comp oral wound up with this treatment plan in my office. And when they showed me her health history, it looked like this. This was her medication list. And honestly, I thought that they were playing a joke on me. And I didn't know them well enough that I would think they would play a joke on me. But I looked at this and I was like, yeah, okay, that's funny. What's her real medication list? And my hygienist looked at me and she said, that is her medication list, Dr. Novi. And I was like, no, come on. I looked at this and I was like, oh my gosh, what am I walking into? Well, what I walked into on my first patient was a patient with recurrent decay around every single restoration in her mouth. She has a history of lupus, fibromyalgia, depression, gastroesophageal reflux disorder, lupus. She has liver issues, anemia, attention deficit disorder, anxiety, migraines. This patient is the epitome of a patient with mixed disease. Mixed disease, notice the yellow star in the corner of the screen. Mixed disease is the term for medication-induced xerostomia disease. This is the term that you can give your patients when their medication list is so long, or you're noticing their mouth is literally on fire with caries because of all the medications they're on. And it may not be many medications. It may be 1 or 2 medications that cause extreme dry mouth. Maybe they're taking albuterol all the time. Maybe they're on an inhalable corticosteroid, which is drying things out. But these patients who are dry as a bone on the inside, maybe they're battling chemotherapy, or they're battling cancer and they're undergoing chemotherapy or radiation. That would also be mixed disease. It's not Sjogren's syndrome. Sjogren's syndrome is going to be different, but of course, any patient with Sjogren's syndrome could also have mixed disease. But this patient, other than the implant on number 29, every single restoration in her mouth is failing. And if you come to my in-person lectures in the future, or we do another webinar, which I think we will, because Viva Learning said to me right before we started, I can't believe you've only done 5 webinars. We should do more. And maybe after tonight, now that I'm building a whole new library of clinical photos to share with you all, maybe we can continue talking about how to help these patients. But I was at a loss for what to do with this patient. I literally said, okay, well, if you are as good at managing caries disease as you tell everyone you are, Brian, roll up your sleeves, put on your gloves, and get to work. And today, we did our 3rd set of a dual tooth restoration. We actually got 24 and 25, we got 20, Katie, correct me if I'm wrong, I think we got 23 and 24 done today. Just circumferential decay around 23 and 24. I had a hard time getting her numb. My back was killing me at the end. I literally, at this moment, I'm rolling around on a spiky ball, trying to get my back to stop spasming after being hunched over, trying to just chasing decay, hoping I wasn't going to hit the pulp in 23. It was a scary endeavor for Katie and I. But all that to say, you meet these patients just like I do, and you want to know what you can actually do to help these patients. So let's turn to the evidence. If I want to do a literature search and find out what restorative material should I be giving patients that's going to resist caries resist caries on the margins of their restorations, what should I be using? Well, we've got a systematic review in JADA that was just published in 2016 on glass ionomer cements preventing caries lesions on the margins of restorations in primary teeth. Systematic review, meta-analysis. So highest levels of evidence we have in the dental literature. Now, the journal doesn't have a really high H-index or index factor, but that's okay. This is a systematic review with meta-analysis in a high-profile journal, and I'm going to quote him: "The secondary caries rate of occlusal restorations was not different among restorative materials. But for occlusal proximal analysis, the glass ionomer cement was associated significantly with better ability to prevent caries lesions." And I think all of us know that if you can prevent caries lesions in an interproximal restoration, it's probably doing a really good job, because patients don't usually clean their proximal restorations that well. So if we can prevent recurrent decay in the occlusal proximal restorations, that's probably a really good sign. Now, the occlusal restorations, there's no difference. Why? Because most people brush the surface of the occlusal surfaces of their teeth. So, but does it matter? Well, it actually doesn't matter. This is a systematic review in primary teeth. So if I'm going to practice evidence-based clinical decision-making, the reality is I don't have a systematic review which tells me that glass ionomer is going to resist recurrent decay best in adult patients. But I have this in primary teeth, and I know that kids don't brush and floss as well as adults sometimes do. And so I'm going to take this and say that that's one piece of evidence. If we want to get out of the evidence base and just get into just some of the research, so this is research-based dentistry now, not evidence-based dentistry, but research-based dentistry. Kind of obviously a pretty highly political, not a highly political journal, but a journal with a high degree possibly of bias, because they're only looking at comparing two different types of the same manufacturer's glass ionomer. But what they found in research of the effects of glass ionomer cements and nano hardness of caries effective dentin is that when you put glass ionomer on dentin that is caries affected, resin modified glass ionomer, even resin modified glass ionomer, resin modified glass ionomer causes the nano hardness of caries effective dentin adjacent to the restoration to increase after 7 days. Oh my gosh, there's a yellow star. So if the question is, does nano hardness of caries effective dentin, is it increased in a matter of time? The answer is it's increased after 7 days. 7 days after we place even a resin modified glass ionomer, and I'm going to say and a glass ionomer restoration, both of them have an increased nano hardness in the dentin, even if it was caries affected. So you can feel comfortable leaving your caries affected dentin and even putting resin modified glass ionomer on them and thinking that the nano hardness, the hardness of the dentin, remineralization is going to occur. It's going to increase even with resin modified glass ionomer. Now today, when I treated our patient with mixed disease, Katie will tell you we didn't use resin modified glass ionomer. We actually used Equiforte fill on that patient because I was so close. Those little tiny lower anterior incisors are so small, and I stopped drilling. I just started spoon excavating slowly, layer upon layer of the soft leathery dentin, now just hoping and praying I wouldn't see big red or the cherry cordial center of the tooth start to blush through. I was just, it was one of those moments where I was like, please, if there is a greater power on this planet, please do not let me hit this lady's pulp. We've got too many other teeth to treat in her mouth. Please don't let me hit a pulp on tooth number 5 and 6 that I'm restoring today. And we didn't. But then I decided to fill her lower anterior teeth with Equiforte fill, a conventional strontium-based glass ionomer, because I wanted to even ramp up the nano hardness of the dentin underneath my restorations, because I was leaving caries affected dentin, folks. I didn't get down to mineral mother dentin. I got down to caries affected dentin, and then I filled them with Equia. So let's back up a bit. I'm talking about a really extreme case in circumferential decay on lower incisors, but let's just back up a bit to just the smallest of the lesion that we treat in practice. This is our classic ICDOS code 1 lesion. Now, I'm also realizing I skipped a quiz question there. There was a quiz question back there, and it was that it had to do with our slide about the systematic reviews in glass ionomer, systematic reviews showing glass ionomer prevents recurrent decay in interproximal restorations of primary teeth. So don't forget to check out that systematic review for your quiz question. But going forward, let's talk about these simple lesions. We all know what we would do with this, right? What do you do with an ICDOS code 1 lesion? The first visual changes of enamel, when you see a tooth that looks like this, what do you do with that? You didn't lose me. I just paused for dramatic effect. What do you do with a tooth that looks like that? Now, some of us would look at that and go, that looks pretty darn good to me. But yours truly, Brian Novi, will do a little fissurotomy. Now, don't do fissurotomies. The evidence says don't do fissurotomies. I do fissurotomies. I think you should do fissurotomies. The evidence says don't do fissurotomies. I do fissurotomies. I like to clean things out. I like to get things squeaky clean. And look, I do a fissurotomy, open up those grooves. Oh, I'm glad I did that. Oh, I'm glad I did that. And I get in there and I take an air abrasion unit. And I'm really excited that just the other day I got my new Prep Start H2O. So I'm really excited to bring air abrasion into our practice here. So I'm going to be using my Prep Start H2O. But in this case, I did a little bit of air abrasion. I get those grooves squeaky clean. I'm down to nice, clean mineral mother dentin. And the question becomes, what do I fill that hole with? I've got a hole in the tooth. What do I fill it with? Now, to answer that question, some of you who know me know that I tell this story of what some dental students taught me a long time ago. This is Danny and Elijah. They came to me when they were first-year dental students. They said, Dr. Novi, can we get your help doing research on fluoride kinetics? And I was like, no, nobody cares about fluoride kinetics. That's boring. And they said, please, Dr. Novi, please, can we just use your fluoride probe to study fluoride kinetics in restorative materials? We want to measure the rate of speed of fluoride ions moving through restorative materials. And I was like, guys, nobody cares. And they're like, we think people care. And apparently the American Association for Dental Research cared so much that in 2012 they did a poster presentation. Then they went on to present at IADR in 2013, all the while showing that they could not get fluoride ions to move through composite resin. And what these guys taught me was that fluoride doesn't move through hydrophobic resins. Fluoride must move with water. And so unless your restorative material is a water-based material like glass ionomer, not a composite because composites are hydrophobic, but hydrophilic materials like glass ionomer that have water in them allow fluoride to pass through because water must always move with fluoride. So any material that's repelling water is also going to repel fluoride. So just remember that when you're looking at these fluoride-releasing restorative materials. If it's not a glass ionomer, the likelihood of it actually releasing fluoride is pretty slim to none. I had another group of students who came to me and they said, hey, Dr. Novi, wouldn't it be cool if we stuck a patient's head in a scan electron microscope and looked at the margins of their restorations in vivo? And I said, that would be cool, but how are you going to keep the patient's head from exploding? Because they tend to pop when you put them in a scan electron microscope. They hadn't thought of that, so we decided instead to just take impressions of their teeth and look at the impressions in the scan electron microscope. This was the first tooth we looked at. Not really much to see here. But it really gets into the detail of what we can see with an SEM image. Now, full disclosure, these images were just originally scanned at 300 magnification. The great thing about a scan electron microscope is you get a very, very high def image. So we can even zoom in on this 300 power magnification image and zoom in even more than we could if we got a higher resolution image, and then you'd lose all the details. So backing up, you're looking at the occlusal surface of a tooth. The cusp tips have been cut off from the impression because SEMs can't see around corners and the cusp tips are too high. Not really much to see here. If you come to one of my other lectures, I'll talk about what some of the detail was, and that's kind of cool. But this is actually a section tooth, looking at the dentin and the glass ionomer interface. You can see the crystalline structure of the glass ionomer on top. You can see the tubules of the dentin on the bottom. And this is really just to show you the detail that we can capture with this polyvinyl ether siloxane impression material allows us to capture dentinal tubules. So if you wonder, is my impression material, again, is it that accurate? Well, this impression material captures dentinal tubules, and this is an impression material that you can get from GC. So this is what we use for our research. Look, it even captures the crystalline structure inside voids of the glass ionomer. But look, where the glass ionomer meets the dentin, there's no gap. There's a chemical fusion zone there, which we're going to talk about. Now, we started looking at amalgam restorations. That's the impression of the amalgam on the left, the tooth on the right. You can actually see the beautiful GV black outline form, almost a reverse S-curve there towards the bottom right hand of your screen. But you can actually see the margin of the amalgam restoration. So if we zoom in on the amalgam restoration, look, there's a gap between the amalgam and the tooth, which is so deep, our impression material cannot capture what's at the bottom of that gap. We look at a composite restoration. I don't think I need to zoom in on the gap for you to see the gap of the composite restoration. Composite restorations don't seal anything. There's always a gap with composite restorations. But when you look at glass ionomer, you see something completely different. Now let me orient you to what you're looking at here. You're looking at the buccal surface of tooth number 19 in a patient that came in with cracked tooth syndrome to the dental school. She had an amalgam in this tooth, and I'm going to go to the next slide because this is what it looked like when we took the SEM. But the amalgam was replaced with the glass ionomer buildup, getting ready to do a crown. Now you can see the cracks coming from that box prep. You can see the old gray haze from the amalgam deep within the tooth that wasn't removed because it was sclerotic dentin. So the dental student left it with his faculty's permission. And then the patient came back for the crown prep appointment, and the patient said, you know what, whatever you did, that tooth feels fantastic. I didn't think I need the crown. And a long conversation ensued, which I'll share with you some other time in the interest of time. But I said, you know, that's a perfect case to share with those 3D3s who are doing that SEM study on restoration margins in vivo. Can we take an impression of that tooth? And that's how we wound up with this impression. Now, if you look at those cracks, you can see that crack that's going down the direct facial, down right from the definite bottom of that box, that crack is now filled in with something. If we zoom in on where that yellow circle is, right here, I hope you can see my pointer. Right here, I can't tell where the glass ionomer ends and the tooth begins. It's chemically fused onto the tooth. There's no gap. There actually is true intimate connection between the glass ionomer and the tooth, because we don't have a bonding agent in our way here. This glass ionomer is creating this mineral fusion zone, an interfacial ion exchange layer that helps resist recurrent decay. And that's what makes glass ionomer so powerful, is that even if you're using resin-modified glass ionomer, we see this interfacial ionic exchange layer that helps resist recurrent decay. So I ask you, if you need to pick a margin for your own mouth, which margin would you want? You can decide on your own, but I know which margin I want in my own mouth, and I know which margin is going to seem, which clinically is probably going to resist decay better than any other margin. And the reality is that this is backed up in the literature. So even in the Journal of Functional Biomaterials just recently, 2016, 3 years ago, we continue to publish papers on the really cool characteristics of glass ionomers. They show a degree of bioactivity that when set causes them to develop that interfacial ionic exchange layer with the tooth, and it's responsible for the high durability of their adhesion to the tooth surface. But people say, Brian, I was always taught that glass ionomers are weak and feeble. Well, I was too. I was taught that sometimes if you fill a tooth with glass ionomer, you might as well have filled it with wax because they don't last that long. But the reality is the research continues to show us that where the glass ionomer meets the tooth, there's an interfacial ion exchange layer that makes that restoration more caries resistant. In fact, the margin of your restoration becomes the strongest part of your restoration now. So why is it then that we see a phenomenon like this? Why is it that sometimes when you look at a glass ionomer restoration, you see these lack of retention events occurring? You see that the glass ionomer is kind of dissolving. I hate to use that word, but it's kind of dissolving in the mouth. Why does that happen? How could that possibly happen? How could that possibly happen to one of our restorative materials? And if your restorative material is actually breaking down in the mouth, is that a restorative material that you want to put in a patient's mouth? Seriously? If it's going to break down? And I hear people saying, no, I don't want to use a restorative material that's going to break down the patient's mouth. But look at what happens when it does. The margin never opens up. The margin doesn't open up. The glass ionomer selectively allows itself to be dissolved away. It actually dissolves away and exposes the burr cut marks on the tooth surface. But if that tooth had actually demineralized, the burr cut marks would be obliterated, and we would actually see this really porous enamel structure developing. But you don't see that with glass ionomer because that margin is so strong, it's going to remain the strongest part of the tooth. In fact, if we analyze the ion content of where those burr marks are, we probably would find that there's different ionic concentration of the enamel where those burr cut marks are than there is out on the other surface of the tooth where there never was glass ionomer, because those ions diffuse between the glass ionomer and the tooth. But why do we see this dissolution phenomenon? That's because the critical pH of the glass ionomer is 0.1 above the critical pH for tooth structure. 0.1 above the critical pH for tooth structure, which means when the patient drinks something acidic, when they drink a Red Bull, a Monster Energy drink, lemonade, Gatorade, Sprite, Coke, you name it, seltzer water, pure carbonic acid, which is just seltzer water, when they're drinking those acidic beverages, when they're sucking on lemons, when they're eating oranges, when they're drinking orange juice, when they put an acid in their mouth, the glass ionomer has the ability to dissolve away, and it's going to do so to protect the tooth. It's a smart material like that. So even though you see this phenomenon, all is not lost, because it's very easy to just go in and add more glass ionomer on top of this. You can simply put some cavity conditioner, weak polyacrylic acid on the top of that, clean it off really well, put some more glass ionomer on there, and you're good for another 3,000 miles. What you may also want to do, and what I've been doing lately on some of my patients who I've been seeing, is that I actually put a layer of a different hydrophobic resin on top of the glass ionomer just to give it a little bit more resin protection, drive the ions of the glass ionomer into the tooth rather than allowing them to escape into the saliva. And I'll talk about that in just a second. So we got off topic because I started showing you SEMs of teeth, but remember it all started with, what do I fill this tooth with? Now, what do I fill that tooth with? Well, you know, let's go to systematic reviews. It's really a sealant, right? I clean up the grooves. I'm really placing a sealant. Someone say I'm doing a PRR. We can turn to the systematic review in JADA, August 2016, published on my birthday. There's nothing like having a paper in JADA on your birthday. And this was the systematic review that we spent 3 years. It was a great group of people at the ADA, and nothing gave me more confidence in our profession than being part of this group of clinicians who were dedicated to reading thousands of sealant studies, and the staff at the ADA who took the time to actually analyze just countless spreadsheets created by the reviewers of all these documents. But at the end of this very long adventure, we found out some pretty revolutionary things. Table 7 of that systematic review actually looked at which sealant material prevents caries lesions better over 2 to 3 years. And what we found in the systematic review, which means we combined all the studies which had similar designs that we could, that had such similar design, we felt that we could pool the data together. And when we pooled the data together, and you get that blue diamond down there at the bottom of this forest plot. So let me orient you to what this forest plot is. So each one of these lines here, each one of these things, like Chen and colleagues in 2012, Arrow and Reardon in 1995, Party and colleagues in 2005, Amon in 2008. These are all the studies that we looked at, which informed our decision to figure out which sealant material prevents caries lesions better. Is it a resin-based sealant material, or is it a glass ionomer sealant material? Now, Chen and colleagues were looking at carious fissures or deep fissures. They looked at 1,282 glass ionomer sealants, 452 resin-based sealants, and what they found was when you're applying it to carious or deep fissures, it looks like resin-based sealant materials actually are better at preventing and reversing caries lesions. When we started looking at fissures with no caries lesions at all, Aaron Reardon did a study in 1995, 412 glass ionomer sealants, 412 resin sealants, very narrow confidence interval over here in the forest plot, but it favored glass ionomer. Party and colleagues in 2005 did a study of 97 glass ionomer sealants, 182 resin-based sealants, wide confidence interval. Some of the resin did well, more of the glass ionomer did well. Amon in 2008, 24 glass ionomer sealants, 54 resin-based sealants, very wide confidence interval, split right down the middle. Basegu and colleagues in 2010 did 628 glass ionomer sealants, 628 resin-based sealants, very small confidence interval in the resin-based sealants are better. But when you go down through all these studies and you meta-analyze the data to create these diamonds, which is the combination of all the data together, you come down here and look, that blue diamond is so far to the left of the line. The middle of the diamond is to the left of the line, but the diamond is not past the line. The diamond is not past the line. The diamond is too far enough to the left of the line that a clinician can look at that and say, well, it looks like it matters, but does it matter with clinical and statistical significance? Not really, because that diamond isn't all the way to the left. And that's because in order to get that diamond all the way to the left, we need to make sure our studies aren't biased. Now, for those of you who are in practice, I ask you, if you do a split mouth study and you do glass ionomer on one side of the mouth and resin-based composite on the other, and then you go back and you look at that sealant 3 years later, do you think you can tell the difference between a glass ionomer sealant and a resin sealant? Do you think you can? I think you can. And so did all the reviewers of these studies, because when you look at the sealant materials that we're looking at, we had the conversation. Could you tell the difference between a glass ionomer sealant and a resin-based sealant? And we all said, those sealant materials they were looking at in those studies, yes, I could. I could definitely tell the difference between which one is resin, which one's glass ionomer. And plus, sometimes the sealant wasn't there. It experienced a lack of retention of it, and it dissolved away. So if it had dissolved away, could you tell? Well, then, yeah, if one side of the mouth is still there and you know how resin sealants behave, you can definitely tell that side that didn't have a sealant there, we know which one didn't have resin because it's the one that's not there anymore. So there's bias in between the examiners because these materials don't look alike. So in split mouth designs, you can't tell. You can definitely tell the difference. That leads to bias, and that's why we can't say that it matters, because these studies are very biased with the examiners. You got to have two sealant materials which look identical in the mouth, and the fact remains, glass ionomer and resin composite do not look the same in the mouth. Any experienced clinician can tell the difference between the two. And so that's what makes this so biased. That diamond isn't all the way to the left of the line. Then we went out 4 to 7 years. Oh, look, there's a yellow star. 4 to 7 years, the caries incidence. When we looked at teeth that were mixed, so they had caries and they didn't have caries. I'm sorry, I have to close my office door because the folks who clean our office are changing out the trash cans. So hold on one second. Come on in. Thank you very much. So we looked at teeth that were mixed with caries lesions and no caries lesions. We looked at teeth that had no caries lesions. And in those 2 studies that we looked at, we only had 2 studies that informed the decision. But in those 2 studies, look, that diamond is so far to the left of the line that you have to say with clinical and statistical significance that if you want to prevent caries lesions for 4 to 7 years, you should be putting glass ionomer in those teeth as a sealant. And so just remember, when you get to that quiz, the ADA had a systematic review in 2016, which found out that glass ionomer sealants are better able to prevent and arrest caries lesions than the resin composite sealants for 4 to 7 years. And this is Table 8 from the systematic review in JADA 2016. This was a groundbreaking moment for the sealant industry. This is the moment where we say, if you want to prevent caries long-term in a child's mouth, you should be using a different sealant material than most people use. And that's why you're not going to find me doing a resin-based sealant. I'm always going to use a glass ionomer sealant, and I'm going to use a restorative glass ionomer sealant material because I get even better results. Now, the good thing that glass ionomers deliver is they deliver the sustained release of approximately 1 part per million fluoride ion available all the time to the tooth. Because it's a water-based material intimately associated with the tooth surface, it's driving those fluoride ions into the tooth. And it's going to cumulatively release this fluoride over time. There's going to be an initial burst for about a month, and then you've got this long-term diffusion of fluoride ions into the tooth, which gives you this total cumulative fluoride release. And if you keep adding things to those materials, you can supercharge them and just keep driving this concentration up. And like I said, recharge those things with remineralizing solutions with things like fluoride varnish. Francisco Ramos Gomez out at UCLA, the guru of pediatric dentistry out there, I call him the Pablo Picasso of pediatric dentistry. Francisco's been doing what he calls the GIFT study, the glass ionomer fluoride treatment study, where he puts glass ionomer on teeth and then fluoride varnish to supercharge them, and is showing caries resistance. But remember, we don't need gigantic amounts of fluoride to make a difference in a patient's mouth. You only need a minute fluoride concentration to initiate and maintain the remineralization process. What's a minute fluoride concentration? Well, according to Franklin Garcia Godoy and John Hicks in JADA, that minute fluoride concentration is only 0.03 to 0.08 per million. So even that slow trickle of fluoride from the glass ionomer, that is enough to shift the remin-demin balance in the dental biofilm, saliva, and in the enamel and drive remineralization rather than demineralization. So in our office, if you come visit me at the Alliance Dental Center, I'm going to open up my closet doors and I'm going to show you my prevention closet. This is just the start of my prevention closet. It's not fully stocked yet because I don't have all the preventive products that I want. I've got most of them, but I don't have everything I need. I want to make sure that my patients, when they leave with a glass ionomer restoration, they're also leaving with products which are going to keep those glass ionomer restorations recharged so they continue to release fluoride. I don't just want to restore teeth. I want to restore teeth, I want to recharge them, and I want those restorations to remineralize those teeth over time. Restore, recharge, and remineralize. I can do that with anything that's going to drive up calcium and fluoride and phosphate concentration in the mouth. So it's no secret the GC would want me to give a webinar where I talk about recharging their glass ionomer restorative materials with things like their wonderful CPP, ACP fluoride products. But I don't want to spend time talking to you about MI Paste because you know how much I love MI Paste. It's like a creamy Jolly Rancher. It's not hard to get a patient to use it. But this is one of those cases where if I don't actively try to keep a patient's glass ionomer restorations recharged and strong with remineralizing ions, patients come in and I see this crater effect. That is a glass ionomer restoration, a DO restoration on tooth number 20. And look at that. It's got a caries lesion in it. And if you look, you can look really closely at that. You see the glass ionomer restoration like, dude, there is a caries lesion in your glass ionomer restoration. That is why I would never use glass ionomer in a patient's mouth. Well, friends and colleagues, why does that happen? This is his mouth. This is his plaque. This guy doesn't remove the plaque from his teeth. When I dye when I dye his plaque with triplaque ID gel to identify where's the acidic plaque, look at the blue plaque in between his teeth. That is pH 4.5 plaque. That's not going to demineralize just hydroxyapatite. That's going to demineralize fluorapatite. It's pH 4.5. No amount of fluoride can stop that stuff. So, and when I say no amount of fluoride, I mean fluorapatite, because fluorapatite has a critical pH of 4.5. So I want to do everything I can to keep those restorations saturated with as much fluoride as possible. Drive up the fluoride content to try to neutralize this plaque, or better yet, put something in this patient's mouth which is going to neutralize those plaque acids. It's going to be drawn to the tooth surface, like the casein protein, and slowly release ions that can buffer those plaque acids over time. Because if you don't do that, you're going to see these restorations, your interproximal restorations, develop caries lesions. Now notice he didn't get recurrent decay, it developed in the glass ionomer. The glass ionomer selectively allowed itself to be removed. So what do I do with that? I don't numb up the patient. I do a slot prep, I put a sectional matrix in there, I clean it out with cavity conditioner, and I squirt in some more glass ionomer, and I patch that thing up. I repair my restorations, and I explain to the patient, dude, your plaque is so gnarly, it's actually eating away your fillings. It's not eating away your teeth, it's eating away your fillings. Please tell me what you're willing to do to make sure that your fillings aren't continuously eaten away by the plaque in your mouth. And this patient, those of you who've heard me lecture, you know this is a patient named Aaron. And Aaron, the only thing he could do, because he had a barrier to actually put in a toothbrush in his mouth, I got him to use baking soda rinses and actually test the pH of his mouth on a continuous basis. Now, we're going to get into periodontics here. Those of you who know me, you know tooth number 19. Tooth number 19 in my own mouth broke off of the gum line. I didn't have a pulp exposure. That's blood from the satanic torture device, which Dr. Mark Carpenter on there in the left-hand corner of your screen, he put that on my tooth. Now, I went to his office late at night. I said, Mark, fix my tooth with a glass ionomer. He put a matrix band around it, 2 wedges, restored it back in 2009 with 2 capsules of Fuji 9 GP Extra. And my goal was to get that restoration to last 2 years. Unfortunately, 23 months to the day it was placed while I was flossing, the mesial broke off. It didn't last 2 years. So I found a dental student whom I trusted. I sat down in his chair. I said, Nathan, fix my tooth. He wanted me to be cooperative, so he dialed up the nitrous. I drifted off to nitrous land, and as I drifted off to nitrous land, I remember Nathan going, Dr. Novi, I'm going to reduce the tooth a little bit. And I was like, oh, what's left to reduce? There's nothing left there. But he identified that there was a little horn of dent that was sticking up so high that he thought it made the thickness of the glass ionomer too thin. So he decided just to cut back the glass ionomer, move the interface between old to new glass ionomer out of the contact area, put in a mylar strip, put in a wedge, clean it. Now this time we use phosphoric acid etch. I wouldn't use phosphoric acid etch. I would just use cavity conditioner these days because I've done enough of these to know I get better results when I don't use phosphoric acid etch. I just use cavity conditioner on them. And then we just build it back up with glass ionomer. That was January 20th, 2011. And as of June 2013, the distal had been on there for 4.5 years. The mesial had been on there for 2.4 years. And then I went to a Caries conference in London, and the whole thing busted off while I was flossing. And you say, well, that's why I don't want to use it, Brian. But do you remember what the prep looked like? So I'm left with nothing on number 19. I found a prosthodontist here in Boston, Dr. Margoliano Muniz, who gave a great webinar last night on using chlorhexidine thymol varnish in practice. But I went to Pam and I said, Pam, fix my tooth, please. And so she did a wax up or she had her lab tech do a wax up, and she did an injection molded Equia restoration in my mouth. This was before we had Equia Forte. So she did an Equia fill restoration March 15, 2015, and we documented it well. Once the restoration got to be 23 months old, we published it. I went back to her office, we took photos of the 23-month-old glass ionomer crown, and we published it because Pam is an editor for Dentistry IQ. So if you want to watch what happened to this tooth, you can go online. This is available for free. Look up the glass ionomer crown. You can go on Twitter, #GICrown. That's #GICrown on Twitter, and read the case report of how Pam actually restored this tooth. I don't want to get into it because the question for those of you who know this tooth over the years, what the heck happened? Well, I was getting ready to do a hands-on course at the American Dental Association when I was eating a whole bunch of sour candy in my bed, which is very acidic. Glass ionomers break down in acid. I weakened it. I woke up in the morning, I flossed my teeth, and my glass ionomer broke. And so I got 4.18 years of success from the least retentive prep ever. There's a prep down the bottom left-hand corner. Text message to Pam, and I said, Pam, we need to write the write-up on how long this thing lasted. But overall, I can tell you, the distal didn't break off at 4.18 years. Finally, the whole thing came off after 4.18 years. But that's the success I've had in my own mouth just with this glass ionomer crown, and I intend to continue keep updating the world with this glass ionomer crown, showing how far you can push the limits with this restorative material. Now, you can do other things with it. People say, Brian, where do I use resin-modified glass ionomer? When do I use conventional glass ionomer? I like to think of it like this. I use resin-modified glass ionomer for class 3s and class 5s because it's more aesthetic and it tends to bend and flex more. Everything else I restore with conventional glass ionomer, meaning the straight-up strontium, calcium fluoroluminosilicate glass, like your Fuji 9, your Equiafill, your Equiaforte. Those I use for almost all. Those are my bread and butter restorative materials. Although today, on that patient who had mixed disease, I wanted to just really, I wanted to drive up the ionic concentration in that Caries effective dentin. And so in those class 3, class 5 restorations in that patient today, on the lower anterior teeth, I actually used Equiaforte fill. And Katie will verify that for all of you. I obviously I don't do class 4 restorations. Those are the ones I use composite on. Sorry, I'm going the wrong way with my slides here. Now, here's a patient where I actually used a conventional glass ionomer in the anterior just to see what would happen. This is a guy who had a habit of rolling around a Castrel Veltrano olive pit on his front teeth every single night. And I said, don't do that. But he liked doing it. So I stopped his habit by building up the facial surface of his teeth with conventional glass ionomer. And I just want to see how these things do in this case, because I typically wouldn't use it like this. But he didn't like those spots on the teeth on the top, so I just filled it with conventional glass ionomer. And I was not happy with the aesthetics, folks. I was not happy with the aesthetics. Katie, remember, this is what our patient today looked like. She had these bright white restorations in her mouth, and I said, "Don't worry. I think they'll blend in over time. I've seen it happen." This is how this guy's restorations looked after a year. Whatever was staining the teeth is now staining in glass ionomer. And look, we got a great shade match 365 days later. So you can use conventional glass ionomer in the front of the mouth, and especially with these amazing new glass ionomers that just have incredible physical properties. I am not hesitant to use them. You're just not going to get the same aesthetic results that you will with the resin-modified glass ionomers. Now, the key to keeping glass ionomers safe and healthy in the mouth is don't dry them out. Don't dry them out. Don't allow your assistant to suction on them while you're contouring them. Don't contour them without copious amounts of water spray. And please, for the love of all things that are holy, let that material mature for 3 to 4 minutes. Even if you're using resin-modified glass ionomer and you light cure it. Just because you hit this restored material with a light doesn't mean it's set. This is an acid-base reaction that's going to completion. So please, whatever you do with this material, put it in the mouth, protect it from imbibing moisture, protect it from drying out. That means coat it in the proper coating agent for the restorative material. Those coating agents that they sell with the glass ionomer, those are there for a reason. I slightly disagree with the instructions that they use because I like to impregnate the surface of my glass ionomer while it's setting with the coating material. So I don't get the whole restoration done and then contour it and then go back in and coat it. I coat it before the material is even set. I say, Katie, give me a drop of my Equiaforte coat. Give me a drop of my Fuji LC, my Fuji Coat LC. Give me a drop of it, and I want to impregnate it. And sometimes even have Katie brush it into the surface so I can just keep manipulating the surface with my instrument. Keep it isolated while it's setting for those 3 to 4 minutes, meaning if it's coated, you've got it protected. Don't spray air on it. Don't put water on it. Sit there and sing a song to your patient. Move on to the next restoration while it's setting. Let that material mature. If you see it turning into Parmesan cheese like this one is right here, it's because someone is drying it too much. If you can start seeing the glass ionomer, it's turning opaque, it's going to fail prematurely, guaranteed. You might as well remove it today and replace it because it's going to be one of those glass ionomers that fails. And you're going to say, why are my glass ionomers failing? It's probably because you're drying them out when you're placing them. Impregnate the surface with the coating agent while it's setting, light cure that coating agent, let it sit for 3 to 4 minutes, and then you're going to have much better restorative success when you contour them under water spray. And if you want to coat them later, I'll show you what I would do for that. And please remember, this cavity conditioner, this is not optional. This isn't optional. This is what you need to use to clean up the surface and improve your bond. Make sure you condition it with the polyacrylic acid. This is a very gentle cleaning agent. It only removes the smear layer. It doesn't remove calcium phosphate from the dentin and expose the dentinal tubules and the collagen matrix. It's not phosphoric acid etch. I know there are people out there, I've got good friends out there who even say, Brian, I get great results using a 5-second phosphoric acid etch, quick rinse before I fill my tooth with glass ionomer. And I've tried it, I don't like it. I want to use the cavity conditioner that GC provides us with. That's what they say to use, that's what I use, and I have great clinical success. So put the cavity conditioner on, rinse it off. If you're using resin-modified glass ionomer, err on the side of getting the tooth a little bit drier than moist. If you're using conventional glass ionomer, go ahead and leave the surface a little more moist. I find that it attracts the moisture. Now, with Katie's help yesterday, we got all this stuff out on our countertop to show you kind of the flow that we use in our practice. We all, starting on the left-hand side of the screen, every prep is treated with cavity conditioner. And then, if I'm filling the tooth with Equia Forte, follow the yellow arrow. I use my capsule of Equia Forte, then I coated it in Equia Forte coat. I light cure the thing, and then I wait 3 to 4 minutes, let it fully mature, contour it under water spray. If I'm using Fuji 2LC or I'm using the new Fuji Auto Mix, either one, I still put cavity conditioner on, follow the green arrows. I use my resin modified glass ionomer, whether it's a triturated capsule or whether I'm using the new Fuji Auto Mix delivery device, and I'm still going to coat them in the Fuji Coat LC. I still want to coat my restorations because it helps protect them while they're setting, helps protect them from imbibing moisture. You get less lack of retention events. And plus, especially with resin-modified glass ionomers, when you apply this coating agent, you impregnate in the surface while it's setting, the aesthetics are amazing. People say, Brian, how do you get such great aesthetics on your class 5 glass ionomer restorations? It's because I'm impregnating the surface with the coating agent. It gives you great translucency. It matches the enamel phenomenally. Then, once it's set, because remember, the light doesn't set it, I still have to wait 3 to 4 minutes. And those of you who are like, I don't want to wait as long as you can. If you're dealing with a squirrely, whirly kid, Katie, remember Teddy today, right before lunch? Oh my gosh. Our squirrely, whirly kid who screamed bloody murder when he tasted silver diamond fluoride. Story for another time. Katie can go in to tell you what that was like for us. If you're working with pediatric patients, if you need to skip the coat, I'm okay with that. If you want to fill your tooth with resin-modified glass ionomer, light cure it, and just hope and pray for the best, I'm okay with that. I just think if you can keep it isolated, it's going to be all the better. If you want to get a really, really nice polish on that, what I've started doing is I started having Katie mix 1 little drop of phosphoric acid with 1 drop of water, and I do a 1-second etch of the whole surface, and then I coat it in PermaSeal. And then I've noticed that those are the restorations which I don't see any lack of retention events. They don't dissolve away because they're coated in that resin. The problem there is now you've lost your rechargeability. So if it's just an occlusal restoration, you've lost your rechargeability of the glass ionomer unless you have a little window that the fluoride can get through. So if it's like a class 2, you can't get that in there. You'll be able to recharge it through the interproximal surface. But on the occlusal restoration, and of course, as the patient bites and wears on it, you may wear away that resin layer on top. That'll give you a little window for remineralization. But for those patients who always say, oh, I don't like it. When you first get it out, it feels a little rough. 2 weeks later, it feels fine, but at first it feels a little rough. Now remember, the assistants who are listening to this, you are responsible for the clinical success. Those of you who want to see my right-hand gal, this is Katie. Katie she's phenomenal. She has found her groove as a dental assistant, and we are having a blast. And she knows that it is ultimately her responsibility to make sure that I get the proper mix and consistency of glass ionomer in a patient's mouth. So how do we do that? Make sure when you're activating these capsules, you activate them properly. Inside that capsule, there is a chamber of acid, there's a chamber of powder. And if you activate the capsule properly, you squirt all the acid in the powder, then you triturate it, and you have a proper acid to glass ratio. If you don't properly activate that capsule, meaning you don't push it down on the countertop, stick it in the gun one time, click it one time, take it out, triturate it, put it back in the gun. If you don't do that, if all you do is push the capsule down the countertop and then triturate it, that's probably why you're noticing the glass ionomer setting up in the capsules, or you can't figure out why everyone likes glass ionomer because you hate this stuff. It's probably because your capsules aren't being activated. Look at the instructions on the inside of the box. It says, push the capsule down on the countertop, push the button in, then stick it in the applicator, click it one time. It'll push the plunger all the way in, release the last little bit of acid in the powder, correct the powder liquid ratio, then you triturate it and you get the correct ratio of powder to liquid. Although you don't have to worry about that if you're using the new Fuji Auto Mix, because the new Fuji Auto Mix, you're avoiding the capsule altogether. But for those of you who are glass ionomer lovers already and you like your gun clicking, one of the things that I found difficult with this is there's no click. It's just this smooth delivery gun that just kind of, I don't even know the right word to use. I want to say it fuses. It just kind of oozes. It gently oozes from the end. I'm always used to having a click with a glass ionomer. It's getting me. I'm having a little bit of a hard time getting used to the gentle ooze that comes from the squeeze of the handle. And so you may want to try this, especially if you're a hygienist and working in a room and you want to do glass ionomer sealants, but you don't have a triturator. I would say use this as your sealant material, because when we did that systematic review on sealants, we found that resin-modified sealants are better retained. They have less lack of retention events. It's because of the resin component. So go ahead and use this as a sealant material. It's a restorative material. Any restorative material can be used as a sealant material, and you get a chemical bonded tooth structure. Use this as your sealant material, and get rid of the resin sealant materials, which we know the research says if you want a sealant to prevent a caries lesion or arrest a caries lesion, you should be using glass ionomer, resin-modified glass ionomer. So if you're new to the world of glass ionomers, I'm going to say start with resin-modified glass ionomer. It's an easy material to use. You prep the tooth, put it in your cavity conditioner, rinse it out, lightly dry it, fill it, coat it, light cure it, wait a couple minutes, polish it under water spray, and go on with your day. This was the first resin-modified glass ionomer restoration I did on tooth number 30 on a patient. What I love about this is that you can see this area of demineralization right in the buccal pit area of that tooth. And I did an apple core prep around this tooth. I replaced the amalgam on top with Fuji 2LC. I replaced the gingival margin decay, which went all the way through the distal onto the lingual. Restored with resin-modified glass ionomer, took this picture, and look, that white spot is going away because it's remineralizing. When white spots are going away, they're remineralizing. Proof that remineralization does actually occur, despite what you hear on the lecture circuit. I have published case studies on remineralization, and it pains me to know that there are people out there in the lecture circuit saying no one has ever documented remineralization in private practice. Well, I have. I published a case study last year in the Journal of the California Dental Association, which those of you who know me, you know that I like to talk about my case with Eddie, where we remineralized his two central incisors. And what did we use to do it? We used casein phosphopeptide amorphous calcium phosphate with 900 parts per million fluoride. Despite what you read in some of the journals, we've got case reports which actually show it works. With that, we need to go to the chat. I can't believe, I thought I was going to have only 30 minutes of slides. I can't believe I've only got 4 minutes for questions and answers, but let's go to the chat. 411 people have been here. Hey, Colonel Holzer. It's always a pleasure to have Colonel Holzer here, one of the original Novi groupies. Colonel Holzer wants to know, will the yellow stars be on the test? Yes, they will, Colonel Holzer. Yes, they will. And just really quickly, let me recount those test questions for you. Remember that when you get a high caries rate associated with multiple indications that causes xerostomia, we call that mixed disease. We've got systematic reviews that show that glass ionomer prevents recurrent decay in interproximal restorations in primary teeth. Nano hardness of caries effective dentin adjacent to glass ionomer restorations increases significantly 7 days after the restoration is placed. And it's the bioactivity of the glass ionomer that leads to an interfacial ionic exchange layer that resists recurrent decay. And don't forget that the ADA published a systematic review. I was one of the authors on that systematic review in 2016, where we showed that glass ionomer sealants are better able to prevent and arrest caries lesions than resin composite for 4 to 7 years. And that was E-figure 8 from that systematic review. All right, let's see. Not a question, but a comment for the host's benefit. Please screen and or refer your patient about 12 minutes in the presentation for TMD and a sleep-related breathing disorder. I advise ensuring the sleep physician is using AASM 1A criteria and are used to score hypopnea with critical eye towards non-hypoxic breathing causing arousals. Very interesting, Sean. Thank you for that. I will go back and look at which patient you are talking about. Hold on. Actually, I'm going to go through. I've printed out my slides. I'm very curious now. Which patient are you talking about? 12 minutes in the presentation. It must have been our patient with the mixed disease patient. All right. I will ask her if she's had a sleep study and get to the bottom of that. Now that I have a cone beam CT machine, I have a whole sleep system here that I've got to get familiarized with. So thank you for that. I appreciate that. That's one of the great things about giving lectures. I get more information from you than you get from me. Shiva's asking if performing Shiva, are you Shiva, my former student from Loma Linda? If performing an indirect pulp cap on a primary tooth, can you fill the entire restoration with Fuji 2 as opposed to placing a liner like Vitribond first, since that is also RMGI? Well, not a pediatric dentist, but I'm going to go out on a limb here. I would fill an entire tooth with Fuji 2LC, and if you're using Vitribond, you're already using a resin-modified glass ionomer, so go ahead and bulk fill with Fuji 2LC. I would just be careful that you sure you are performing an indirect pulp cap and not a pulp cap, because you don't want to put glass ionomer on the pulp. The polyacrylic acid no, let's be honest, it's cytotoxic. So pulp cells don't like polyacrylic acid being put on top of them. Let's see, Alex, or looks like someone who might be named Alex. Are you using the sandwich technique for class 2s with glass ionomer and composite? I use Fuji 9 and it says not to be used for class 2s. Well, you can rest confident or you can practice confidently using Equia Forte for your class 2s. I stopped doing sandwich techniques a while back because the layer of my meat in my sandwich, which was my glass ionomer, just kept getting thicker and thicker and the composite kept getting thinner and thinner. And I would say that now I'm kind of doing like a very, 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 maybe it's like a New York style deli glass ionomer sandwich technique where I bulk fill with the glass ionomer, coat it, light cure it, wait, contour the thing under water spray. And now that I've removed my coating agent, which is really just an isolating resin, in that case, what I do is then I go back in with that quick little phosphoric acid etch. And just, we're talking 1 second. Katie, we rinse and dry the tooth lightly, coated in permaseal. And those are the ones that I'm seeing. I don't see them wearing away at all. We're getting incredible wear resistance when we coat them. And I have to say, I see the same thing when I use the Equia Forte coat or the Fuji Coat LC. I see the same wear resistance as well with that. The difference is that sometimes if I'm having to adjust the occlusion and I'm breaking through that, I just found that it doesn't bond really well to glass ionomer, which is already set, which is why I like to impregnate as it's setting and try to get that anatomy as close to possible. But if there is any spot where I'm actually adjusting a little bit more, then I like to coat it in something that's a little bit more, let me say, thixotropic maybe. The thing about the coating agents, and I know we probably have some folks from GC listening to this, and I hope you're not going, oh, Brian, what are you doing? The thing with the coating agents are with the glass ionomer materials, those coating agents are very hydrophilic resins, so they're attracted to the water in the glass ionomer. So if you're waiting till the very end and you're drying off that glass ionomer, there's no water for it to be attracted to, which might be why it's not sticking really well. Does the coat stop rechargeability? It does if the entire restoration is coated, but again, I think patients tend to wear through that coating agent pretty quickly. So once you get a little window worn through, then those things are able to remineralize or recharge, excuse me. Where does silver diamond fluoride fit in my protocols? I use silver diamond fluoride copiously. You can ask Katie. Katie, remember the big black spot on top of our brand new quartz countertops? Katie and I learned that day that Clorox wipes are great to get rid of that stain on countertops. I was blown away that Clorox wipes cleaned up the silver diamond fluoride stain. And someone has now recently told me that the Mr. Clean Magic erasers are amazing for removing silver diamond fluoride stains from your countertops. So try that if you're having problems with SDF stains on your countertops. But yes, I typically use silver diamond fluoride at exam appointments for patients just to stabilize caries lesions so they don't get any bigger. But we also apply silver diamond fluoride during restorative appointments, especially like on these extreme caries risk patients. If I see some soft areas of demineralization on root surfaces, I always apply silver diamond fluoride. I'm a huge fan of silver diamond fluoride. We can talk about that in another webinar. Please speak towards restoring teeth after replacing SDF. Well, Elizabeth, you're making me go there. All right, so after I place silver diamond fluoride, the great thing about it is that the tooth is going to be the caries is going to be arrested. So if I touch that with a spoon excavator and it is rock solid, granite hard, I don't prep the tooth at all. I just restore. I just put cavity conditioner in, clean it in, and restore it. I don't even anesthetize the patient. But I tend to try to get back in there and scoop out what I can just to make sure that we don't have a whole lot of softened tooth structure. And Michelle, you're welcome. Good to have you on here. Let's see, clinically, how do you distinguish between affected dentin and carious dentin? Oh, fantastic question. So affected dentin is going to be the hard dentin that if you're trying to cut it with a slow speed handpiece, it may be a darker color, so it's affected. But when you cut it with a slow speed handpiece, it kind of comes out like dry sawdust. So Doug Young does a great description of caries infected dentin being anything soft and wet is infected. If it's dry, it's caries affected. And I'm confident leaving caries affected dentin and putting conventional glass ionomer on top. What did I use to remineralize Eddie's central incisors? I used MI Paste Plus. Although it all started with Eddie just brushing that one area, then it went to Eddie, can you leave toothpaste foam in your mouth before you go to bed at night? Then it went, because Eddie didn't like that, we tried to use fluoride mouthwash, he didn't like that. And that's when we tried having him brush his teeth. And GC America, close your ears right now. But that was back before we had MI Paste 1. And so without MI Paste 1, We weren't supposed to use MI Paste as a toothpaste, but Eddie was using MI Paste Plus as a toothpaste. Someone is going into the chat. I haven't opened the chat. Oh, I am getting a signal from Viva Learning to wrap it up. Okay, I promise I will wrap it up. I didn't realize that I would get in trouble. I thought I could go over. Okay, oh my gosh, we are going over. Okay, what would you do if you have a class 5 prep where gingiva won't stop bleeding? I would scrub Astringent X into that. Do you use Gluma before placing glass ionomer? No, I don't use Gluma because that's a resin, and I don't want to put resin on the tooth before I put glass ionomer on there. So all I do is I prep it, I use the cavity conditioner, I rinse it off, and I inject my glass ionomer. Why not put a couple of dentin pins into your tooth for retention of your glass ionomer restoration, especially when there's no tooth retention? Is it contraindicated with GIs? It's not contraindicated with GIs, but I'm allergic to pins. And plus, I want to see how far can we push the bond. So that's what I'm really testing with my glass ionomer crown. When do you use SDF? How often do you use SDF? I use SDF every day. I use it during exam appointments to try and arrest caries lesions so they don't get bigger in case I don't see and if I don't see the patient back soon. Does the strontium increase compressive strength? Yes, it does. Strontium really improves the physical characteristics of the glass ionomer, which is why I love GC glass ionomers, because they're strontium based. Let's see, can you get a good contact? I do. I get great contacts because I use the Triodent matrix system. Do the coatings need to light cure? Yes, they do. Does SDF stain through glass ionomer? Well, there's a good question. Yes, I have put silver diamond fluoride on teeth. I've rinsed it off. I put glass ionomer in there, and then I didn't coat them because I don't want to make silver diamond fluoride part of my restorative procedure because then everything turns black. Don't make that mistake. Don't use silver diamond fluoride during your restorative procedure. Everything turns black if you hit it with a light. And you will over time see the glass ionomer kind of imbibe the silver phosphate, and 1 year later you'll see a dark line around your restoration. 2 years later, that nice, beautiful aesthetic glass ionomer will look like an amalgam. Let's see. Let's see. I think that's it. I think we got through all the questions. Last question. And I'm sorry, everyone. The question it's blowing up right now. And I'm getting the hook from Viva Learning because some of you wanted to go take your quiz. So check out my website www.holymolar.com. That's www.whollymolar.com. Like a whole molar, not a hole in a molar. Last question, Jeff, can you use glass ionomer and access through crown after endo? I think that is a perfect indication for the use of glass ionomer. And with that, I am done. Thank you all for letting me spew forth my ultra-liberal, caries arresting philosophies. And you have done me a huge honor by sticking with me today. And with that, Novi out.